Greetings, friends of liberty. Although we English have experienced the usual trials and tribulations that accompany sickness and health in this, the 18th century, 'tis also true that we have been happily surprised by the many recent inventions and discoveries of numerous medical pioneers and doctors. These all portend an ever-increasing lifespan for all of us, and even perhaps an eventual return to that alleged Garden of Eden, from which Jehovah so rudely expelled us, all for the crime of eating an apple, which gave us knowledge of good and evil. Now, if I were Jehovah, I would have done the precise opposite, and rewarded sweet Eve for her thirst for knowledge. The good Lord knows that there certainly are no end of people in this world of ours who desire to remain ignorant. But on the subject of recent medical triumphs, amongst the most notable, we find the progress of vaccination, which was introduced initially as a form of inoculation by Larry Mady Wortley Montague in 1720. Lady Mary, traveling to Turkey with her husband, the ambassador, there saw the effectiveness of introducing small amounts of pus from the sores of a person with a mild case of smallpox into the open wound of a healthy person who subsequently was rendered immune to the severe form of smallpox. Later, in 1774, Benjamin Jesty discovered that a similar inoculation from a harmless cowpox sore can actually prevent the occurrence of smallpox, the lesser illness preventing the greater. Extraordinary. Other discoveries, many by the Scots amongst us, have been the numerous advances in obstetrics, with Dr. William Smellie, in his path-breaking treatise on the theory and practice of midwifery, explaining the beneficialness of using obstetrical forceps in facilitating childbirth, thus reducing the chance of injury to mother and newborn alike. He is one of very many Scottish doctors found in London today. Now, if we turn to the question of the improvements in medical science in your own 21st century in America, we find the extraordinary instance of a national healthcare system that continues to make some improvements, but that, since it is so funded and controlled by government, is at least twice as expensive as it need be. In Priceless, Curing the Healthcare Crisis, economist John Goodman, graduate of Columbia and author of numerous healthcare books, here reveals the mechanics of this dysfunctional system, showing how badly it performs compared to its potential. Goodman begins by outlining the challenge facing anyone wanting to understand it, its enormous complexity. There are tens of thousands of state and federal laws, hundreds of judicial rulings, and numerous public and private medical and insurance systems, such as Medicare, Medicaid, veterans, military, union, and Indian insurance systems, all of which overlap and intersect. How then can we ever grasp how it works? Goodman's answer is to start by looking at incentives. As he says, we are caught up in a dysfunctional system in which perverse economic incentives cause all of us to do things that raise the cost of care, lower its quality, and make access more difficult. Perverse incentives are faced by everyone: patients, doctors, nurses, hospital administrators, employees, employers, and so on. What are some examples of these? Number one, in the United States, perhaps the most fundamental and destructive was the fact that, since the start of federal income tax in 1913, income used for employer-funded health care was tax-exempt, unlike all other income, resulting now in 90% of American health care funded out of an employee paycheck. This means, A, when people move to another company, they lose their insurance, which then motivates that next company not to insure them, partly because the second company isn't allowed to charge higher premiums if they're needed. Also, insuring pre-existing medical conditions is harder with workers moving from job to job instead of simply having independent insurance that, as all of us do with life, house, and car insurance, stays with you no matter where you work. B, states have passed laws which force employers and insurers to charge the same amount to people regardless of pre-existing conditions. This then incentivizing those people to delay purchasing health insurance until they get sick. Cost now rises artificially and unnecessarily because now more sick people are in that insurance pool, which then makes fewer people want to buy insurance because it's even more expensive. As Goodman says, in the state of New York, this sort of regulation has produced staggeringly high premiums. C, many countries around the world have as their ideal a healthcare system free at the point of delivery. But this obviously incentivizes consumers to demand too much healthcare because they simply don't have to pay what it actually costs. So, for example, getting a pap smear every 4 years costs $12,000 per year of life saved. But getting one every year? It then costs $1,500,000 per year of life saved, since there is so little value in getting one every year. Do you imagine that the principle of free at the point of delivery is either moral or effective in any other area of society? Do any of us imagine that because food is so vital for living, we need to make food free at the point of delivery? No, we want the price of food to reflect what the actual costs are of making and supplying it. And then, if there are hungry people, we can give them food or money for food. D, because in America, on the average, every time we spend $1 at a physician's office, only 10 cents comes out of our own pockets. Not only is demand artificially increased, but everyone has to wait much longer for care. In other words, the time price of care increases enormously. Everyone waiting in emergency rooms for GP and specialist appointments, and even in the doctor's office itself. E, another perverse incentive, or at least result, is not just all the waiting, but the reduced ability of the healthcare system in other ways to actually treat their patients. So, for example, Canada, with its universal system, has, per capita, only 10% of the PET scanners that the US does. Similarly, Britain has few CAT scan machines, even though we invented them, and relatively few kidney dialysis machines. So in the absence of prices rationing care, the absence of actual medical equipment, as well as waiting, rations care. But isn't healthcare a right in Canada and the UK? Incidentally, about 1/5 of all American consumption is spent on healthcare, with spending increasing yearly at twice the rate of growth of income, one of the reasons why America is going bankrupt, with unfunded Social Security and Medicare liabilities now estimated at $175 million. Number 2, so having discussed perverse incentives as the first cause of raised prices and lower quality, we can next ask, what do all those bureaucrats and politicians do when they see people responding to all the perverse incentives? They create more and more laws to try to control and regulate and mandate the behavior of all those allegedly greedy or ignorant or free-riding patients, doctors, and insurance companies. And because bureaucrats have no knowledge compared to the doctors who have studied and worked for many years, and compared to patients who know themselves very well, the bureaucrats need to collect huge amounts of information just to price procedures. that can easily be priced by those doctors and patients who already have that knowledge because they're there. So, for example, A, the Scripps Memorial Hospital, a medium-sized acute care facility in San Diego, California, had to answer to 39 governmental bodies and 7 non-governmental bodies, and periodically filed 65 different reports, about 1 report for every 4 beds. In most cases, the reports were lengthy and complicated, requiring the daily recording of information by highly trained hospital personnel. To gather all that information costs lots of man-hours, and is one reason why aspirin sometimes costs $10 or more per pill when you take it in your hospital bed. B. Another example is simply all of Medicare, which tries to set prices for over 7,500 procedures, which, with 1.1 million American doctors, would be theoretically setting billions of prices. As a result, they really have no clue, and so some prices are too high, others too low, and doctors are incentivized to mistrain for the wrong procedures. C. Because prices are artificially set for drugs too, there are often drug shortages. So, for example, Doxil, a drug used to treat ovarian cancer, is often not available for patients who need it. D. One typical Medicare rule is that doctors can only treat one condition per visit. So instead of a doctor treating 4 conditions in one visit, the patient and doctor have to schedule 4 visits. Of course, as one doctor said, you could spend the extra time and deal with everything, but you are completely giving away your services to do that. Number 3. Now, having seen the regulations throughout the whole system, let's note some of the additional harmful consequences. A. Hospitals are dangerous places to be. By one estimate, as many as 187,000 patients die every year for some reason other than the medical condition that caused them to seek care. To put a dollar figure on it, this is equal to between $4,000 and $10,000 a year for every household in America. B. In addition, the bureaucrats also bizarrely don't reward doctors when they save money for them. And that's because the system is not a for-profit system, which would care about prices. So, for example, we see Dr. Jeffrey Brenner of Camden, New Jersey, who discovered that of the 100,000 people who use Camden's medical facilities over the course of a year, only 1,000 people, just 1%, accounted for 30% of the costs. And so Dr. Brenner went out voluntarily and found ways to reduce that 30% significantly. But did the government, in its indifference to price and profit, reward him? No. In fact, Brenner is able to do what he does only because of grants from private foundations. C. Similarly, electronic insurance exchange systems, which allow patients to purchase insurance, already existed before Obamacare, as did sensible, workable electronic record systems, including the ability to electronically prescribe drugs, which have been in use for over a decade by walk-in clinics, by private telephone and email consultation services, and by concierge doctors. T. North American Surgery, an enterprise that facilitates medical tourism, has negotiated deep discounts with about 24 surgery centers, hospitals, and clinics across the United States. Do you think the governmental system is going to try to reduce your surgery costs by facilitating medical tourism that allows you to shop around for the best price and quality in all 50 states? Are you kidding? As Goodman says, even MRI scans vary by over 650% in a single town. Number 4. Now let's turn briefly to the third and final major contributor to high prices, the large number of malpractice suits. Goodman estimates they amount to as much as $2,500 per household per year. Court systems often allow huge damages, many times over the actual harm that an individual patient has incurred. But if that system were private and not public, not only would the quality of the healthcare system overall be significantly improved, thus lowering the frequency of malpractice suits, but also the extent to which doctors practice unnecessary and expensive defensive medicine would be lowered. Interestingly as well as in other areas of American society are the many incorrect beliefs, orthodoxies, and ideologies that pervade this largely governmental system, used by its defenders to justify and evade the enormous harms their medical coercion creates. First is the belief that increased spending will result in better quality care. But results do not show this. With Medicare, researchers have studied across the 50 states, across hospital regions, and across Veterans Affairs regions, and found that large variations in healthcare spending apparently have little, if any, impact on overall population mortality. And that's because the increase in spending is just used by the government to throw money at problems instead of fixing them. Think President Biden and his so-called Inflation Reduction Act. A second orthodoxy is what Goodman calls the public-private double standard. So, for example, if a private insurance company denies a breast cancer patient a bone marrow transplant, that's considered a moral outrage. But if the Arizona medical program denies people organ transplants that do work and save lives, that is considered an unfortunate budget issue. A third orthodoxy, by those who think they know better than everyone else how to run a healthcare system, is to stipulate for every doctor how they should treat every patient who has a certain illness. This cookbook recipe approach is increasingly used, in effect treating doctoring like engineering. But this attempt at cost-cutting fails since, number one, doctors often disagree on how to treat patients with the same conditions. Number two, patients differ, often radically. And three, many clinical trials are done by excluding certain subgroups, who then are nonetheless included in the treatment groups. Ironically, however, when private groups and hospitals develop their own protocols, these tend to work, as with the superlative Geisinger health systems in central Pennsylvania, where doctors follow 40 specific steps before performing elective heart bypass surgery. A fourth fallacy that possessed the mind of President Obama was that the key to healthcare reform is just getting everyone insured. But did Bam Bam concentrate on increasing the supply of healthcare too? No. And the same fallacy possessed Governor Mitt Romney in Massachusetts a few years earlier, with more people being covered in Massachusetts by insurance, but supply there as well not increasing. So outcomes and waiting time actually became worse. Even internationally, if we compare the universal coverage of the Canadian system with that of the American, do we find better outcomes? No, since A, uninsured Americans get as much or more preventative care than insured Canadians. B, since low-income populations in America do better. And C, since people in American emergency rooms get better care. And of course, in the UK, the problem of unequal access, despite alleged universal coverage, is known as the postcode lottery. Non-elderly Britons living in areas with the worst performing hospitals were 42% more likely to die on any given day than the average for Britain as a whole. To further illustrate the relative American equality of care between the insured and the uninsured, Goodman gives us the case of Parkland Hospital in Dallas. Both uninsured and Medicaid patients enter the same emergency room door and see the same doctors. The hospital rooms are the same, the beds are the same, and the care is the same. As a result, patients have no reason to fill out the lengthy forms and answer the intrusive questions that Medicaid enrollment so often requires. Furthermore, the doctors and nurses who treat these patients are paid the same regardless of patients' enrollment in an insurance plan. It should be noted that at Parkland, they make strenuous efforts to enroll uninsured patients into Medicare, but only enroll half. And this is likely because potential enrollees suspect or soon discover that the difference in care is minor for many procedures. So why enroll? In addition, if a patient's income rises and falls through the years, they may qualify in some years but not in others, which means a constant time-consuming process of re-enrolling time and time again. In addition, for their part, hospitals often receive such low percentages of payment for their Medicaid clients, less than 10% of the full charge, that there isn't much point anyway. Moving to our final section, what are the solutions that Goodman advocates? He goes into great detail and length, but briefly they involve privatizing the system step by step, making portions of it more and more free. In other words, since free or highly subsidized care is already largely available in the United States, what is needed is not an alternative to free care, but a way to subject the free care system to market forces. Essentially, this means giving patients a larger and larger percentage of the monies that would be spent on them, either with health savings accounts or direct grants or tax credits. How do we know that this would work, other than recounting everything I just mentioned? One reason is that studies show the classic investigation of this issue was conducted by the Rand Corporation about 30 years ago. In that study, people with a deductible of about $2,500 cut back on spending by about 30% relative to people who faced no out-of-pocket costs. And there was no negative impact on health from the higher deductible. A newer study found essentially the same savings, 30%, again with no difference in health outcomes. Internationally, in Germany, long-term care patients who agree to manage their own budgets spend 50% less than what they would have spent in a normal plan. In the Netherlands, spending is 30% less. Another piece of evidence is that the few parts of the American healthcare system that aren't controlled by government, LASIK eye surgery and cosmetic surgery, have had significant improvements in quality and reduced costs for decades. Completely the opposite to the governmentally controlled system. Goodman also suggests, among other liberating actions, to allow qualified personnel who aren't doctors, such as midwives, assistant physicians, and nurse practitioners, to perform any procedures that now only doctors are allowed to do. B, allow medical tourism between all states to be reimbursed by all forms of insurance. And C, allow doctors to bill patients when using the telephone and email, which is often now not allowed. In conclusion, this is a brilliant book, which does exactly what Goodwin intends: explain why the very complex American healthcare system is as dysfunctional as it is and how to fix it. I would give it an unqualified A, and I'm awaiting his second edition coming out in September, which will focus on documenting and explaining how destructive Obamacare has been. Very happy for my part. The Scots are coming down from the Highlands to learn medicine and then treating us in London, pulling their own weight in our blessed union. I bid you well and remain the Scarlet Pimpernel.